Greetings, I'm Heidi Noss from Madison, Wisconsin in the AIDS Treatment Activist Coalition, and I'm here with two researchers who have brought some data to the 21st CROI 2014, and I want to introduce them to you. Can you guys just say who you are, where you work, and maybe what your area of research is?
Sure. My name is Christy Stringer. I am a medical sociologist at the University of Alabama at Birmingham. I'm currently a predoctoral fellow with the Centers for Outcomes and Effectiveness Research and Education. And my area of research is health-related stigma. So I look at how stigma affects someone's health outcomes.
Okay.
Heidi, it's nice to be here with you. I'm Sharon Hillier from the University of Pittsburgh, and I also work with the Microbicidal Trials Network. My area of research is really reproductive health and HIV prevention in women. And the work that we brought here to the meeting had to do with the development of new products for women to protect themselves from HIV.
And your background is like bacteriology, microbiology, right?
Right, exactly. I'm a PhD microbiologist by training and started out working in bubonic plague.
And Christy, medical sociology.
Right, I'm a social scientist.
It'll be interesting to talk to you two about this meeting. And Christy, for you, the first CROI you've been to, yes?
Yes.
So I know you do general stigma research, it sounds like.
Yes.
And so HIV is maybe a newer field for you.
It is. I've been doing HIV research with my mentor for about a year and a half now.
So can you tell us, I don't know if this is too hard to do, but can you somehow try to summarize the poster that you presented here at CROI?
Sure. We had data that was collected in rural Kenya with pregnant women. We did 3 different surveys, one before their antenatal visit, their first antenatal visit.
So that's while they're pregnant?
While they're pregnant,
Okay.
before their HIV test, and we looked at anticipated stigma. So if you were to test positive today, how likely is it that you think these things would happen to you? And then late in pregnancy, and then 4 to 6 weeks postpartum.
And so when does the HIV test happen in there?
At the very first visit.
Okay.
So right after the survey. So
Okay.
we talk to them while they're in the waiting room, waiting to see their doctor for the very first time. And so the analysis that we presented here at CROI looked at postpartum depression. And we looked at how linkage to care may impact postpartum depression. And of course, we found that women who were linked to care were less likely to experience postpartum depression, also less likely to experience internalized stigma. And then we looked at the role that stigma played in that relationship. So we looked at the relationship between linkage to care and postpartum depression, and found that much of the reduction in postpartum depression was actually explained by reductions in stigma.
So you had measures that could allow you to separate out depression from stigma.
Correct.
Elements of stigma.
Correct. And they definitely had, they were both still significant, but they had very different impacts, significant impacts on their own.
It's interesting that your poster focused on stigma. Am I right that is it the only stigma research here?
It is. I was actually surprised to find that. With as far as I could see within the schedule and within the presentations, it was the only poster focusing on how stigma impacts linkage to care.
How did people react when you presented your poster? So when you're standing by your poster for your allotted time, people approach you. How did they react?
A lot of people were really interested. They were glad to see that some of the social psychological aspects of linkage to care. I was very surprised. I had one gentleman actually walk up to me and say, "Has anyone ever done research on HIV stigma before?" And I was flabbergasted that you know, this awareness of how stigma affects one's care, not only one's engagement and retention in care and medication adherence, but we also have evidence that stigma actually changes the body. You know, it has biological effects. And
Stress hormones.
Cortisol.
Sure.
Cortisol is produced,
Immune system.
inflammation. Yeah, so it was really disappointing to find out that there wasn't that much understanding of that. On the other side, several of the presentations did talk about stigma and how it affected
One by a certain
right,
yeah.
which was probably the one that stood out to me the most. But there didn't seem to be a lot of research presented just on stigma and
So
effects.
we got to hear from you about your presentation. But I will say when I was doing, I just put in the word stigma in the abstract book that lists all of the abstracts. And it came up a lot, sort of in the conclusions where it would say, so possible causes for people not coming into care or not staying on treatment or whatever it was. One of them might be stigma. But there was no other outright study looking into stigma.
It seems to be buried in the discussion
Yeah,
section.
right. And so maybe that means we're on our way to it coming front and center, you know. So Sharon, will you tell us a bit about your presentation and your research?
And I'm really excited to talk a little bit about stigma because I'm somebody that didn't used to think about it very much. As I said earlier, I work primarily in HIV prevention. And so to me, prevention is a health promotion activity. And it never occurred to me that something you do to keep yourself healthy could carry stigma with it.
Yeah.
But then in the study we did, the large randomized study of oral PrEP versus topical PrEP.
Can you define PrEP?
PrEP, pre-exposure prophylaxis. So we looked at drugs like Truvada or tenofovir, as well as a vaginal gel containing tenofovir.
And that's a nucleoside that's been around a while.
Been an approved drug for a long time.
Now we're just applying it to the skin. Okay.
And so these were women living in Uganda, Zimbabwe, and South Africa. And what we found at the end of the study, which was heartbreaking to all of us, is that only about 1/3 of the women actually used the products to which they were assigned. And that led us to really being unable to determine whether or not these really exciting interventions worked in these high-risk young women. Over half of our women were less than 25 years of age. So we were talking about predominantly unmarried young women who really carry the burden of HIV within sub-Saharan Africa.
Yeah, maybe the most critical population globally.
Absolutely.
Yeah.
And so we were really heartbroken to find out that only 1 in 3 women really used it. So we've gone back now to interview the women with the blood tests that we've done to see whether or not they actually took the drug. And we've asked them, had the chance to come back to some of the women and say, well, what happened exactly? Why didn't you use your product? And what we've uncovered in those interviews is so much stigma. Mm-hmm. People tell us, you know, I was afraid someone would find my antiretrovirals in my drawer and they would think I was really infected. Mm-hmm. Or they would think that I was hiding my status from someone. Or that my boyfriend would think I was cheating on him. Or why would I need such a thing? And so that there was stigma associated even in HIV uninfected people with the notion that they would be stigmatized by being considered HIV infected, or that somehow they were people who couldn't control themselves, and that's why they had to use biomedical prevention. So my eyes have really been open to the high cost of stigma in the study populations we work that I think undermine women's ability to utilize exciting products that can really work.
It does seem like we're at a different juncture. I mean, you're talking strictly about prevention, but even when you think about treatment, and really globally we're talking about diagnosing people faster, getting them on treatment quicker, and keeping them there, basically. Right. That's another way to really squash the epidemic. Right. But to do that, we really, it's becoming very clear, have to address all these things. You can have the best medication in the world, but if someone is sitting in fear that having that in their possession is going to out them as having HIV, it's really not of much use to them. So until we really start understanding this aspect better.
Yeah, one of the most striking things to me in my travels when I work in the communities is I was visiting a pharmacy in Zimbabwe, and they said even for prevention of mother-to-child transmission, that people have learned to put extra cotton wool, as they call it, or cotton balls into their pill bottles, because even the sound of pills rattling in your handbag or your pocket make people think you must be infected. And so it's really taught me that no matter the context, whether you're HIV infected and getting treatment, you're uninfected and trying to access new prevention modalities, or you're a mother taking drugs to protect your baby, there's stigma associated with HIV. And we need to get that really out of the closet. We can't address it or give people ways to manage the stigma unless we start to talk about it.
I'm eager to hear your reaction. Did you see Sharon's presentation?
Yes.
So what was your reaction to it as a stigma researcher?
As a stigma researcher, I do quite often look at retention and care. I look at health behaviors among people who are positive. I look at health behaviors that affect mother-to-child transmission, that affect utilizing skilled delivery services. It had not actually occurred to me the stigma that may be associated with PrEP and just protecting yourself. And I agree, we're never going to get past these barriers until we get stigma out front and center to talk about the effects. And, when I was listening to your presentation and how stigma affected PrEP use, I started thinking about, I've heard people say, well, you shouldn't give people PrEP because that just gives them a license to engage in these risky behaviors. And it's the same thing we hear about comprehensive sex education. We shouldn't teach people how to protect themselves with sex education because then that gives them a license to go out and have sex. It's the same thing we hear with harm reduction, needle exchanges for substance users. It's no, we shouldn't give them a way to protect themselves because if they do it, they deserve it, kind of thing. So it hadn't crossed my mind, and I'm actually sad to say that I hadn't thought about that.
Well, it strikes me that we in this country, millions and millions of Americans are on Lipitor or other kinds of cholesterol drugs to prevent heart attack. And we don't say to a person who's overweight, actually, I'm not going to give you that Lipitor because then you might eat too much dessert and feel like you really don't need to exercise. So I'm sorry, until you show me you can control yourself, I'm not giving you that Lipitor. And yet, because it's about sex, because it's about sexuality, we somehow still think it's okay to say, well, we aren't going to give you that medicine that might help you because you really need to control yourself.
And what strikes me about some of this is some of these conversations even happen in scientific rooms. And what's curious to me about that is that sort of mantra or attitude bumps right up against scientific data. If you have a tool that's been proven to, let's say, prevent transmission or reduce harm, why wouldn't you use it, right? I mean, aren't you really then obligated, in the interest of public health, to set aside your own judgments or assumptions or fears? And now I think there is some data showing some of these assumptions are actually not true. We're not in a position to give people permission, so to speak, to do anything as clinicians or really as a friend, as anybody. There is no, maybe a mother or father, but that's about it, So I mean, it's very interesting. The language is interesting. The presumptions are interesting. And we're sitting here with, in the other hand, having scientifically proven prevention tools. I mean, it's really fascinating in a very sad way to me.
Yeah.
So I don't know if you had any other comments on that, but I wanted to ask you, too, if there was, we've been at CROI now, this is our 4th day, and I'm wondering if there's any other, just in general, research that really struck you or you were, taken by, or any other kind of aha moments that you might have had, or things you think are critically important that you're happy to see, or what do you walk away from here thinking about, I guess?
Well, I think certainly one of the bits of data that was presented yesterday that I thought was pretty interesting was an update on this ongoing debate about hormonal contraception and HIV risk. And so there's been a lot of consultations with the World Health Organization and many studies. Some have shown some excess risk of HIV or HIV shedding when women are on hormonal contraceptives. So I think as women's health advocates, those of us who work in this area want to always ensure that somehow there's not an attack on women's ability to prevent pregnancy or use family planning. On the other hand, as researchers, we really want to critically look at the data that's evolving. So a presentation that was made by Lisa Noguchi she is a doctoral student at Johns Hopkins University, and she did an analysis of women enrolled in the VOICE trial in South Africa and showed that women who chose Depo-Provera as their method of birth control did have a 40% excess risk of HIV acquisition compared to women using other injectable forms of contraception. So I think, again, it calls us to really think about how we make sure that women, wherever they live on this planet, have a range of contraceptive choices. That, in fact, if they want a non-hormonal method, like an intrauterine device, or they want access to oral contraceptives or implantable devices that are broadly available, that those choices are available to them. Unfortunately, what we find in the communities we work at, whether in the United States or internationally, oftentimes women have a choice of a pill because it has a high copay, or they have a choice of potentially something else that's less costly and maybe not the longest, best option for them. So I think one of the things that I'm still struck by is that in the era of HIV prevention, we really have to pay attention to methods that might increase the risk of HIV and ensure women have choices.
Yeah, I mean, what person on the planet, if you were just to ask random people about anything really, so would you rather have a choice or not have a choice? Every single one of us, no matter what it is, we're going to say, without even knowing probably what it is, I'll take the choice.
Right? Yeah, we like
this
choices.
Is not rocket science, as they say.
Right.
You know?
And so I think sometimes choice within communities is limited by what's inexpensive. Depo-Provera is a very inexpensive option. And so I do think we need to push funders and push programmatic people who bring in contraceptive options for women, whether in the U.S. or internationally, to make sure that women actually have an actual choice.
And I would think, too, one aspect is reducing the actual financial cost, but also looking at it in a broader context of costs. There are costs to somebody using something that increases their risk of transmission by 40%.
Right.
There are costs to not having a choice. There are costs to, almost conducting care in an almost patronizing way, like, you'll do this, you'll take this or nothing,
Right.
There are costs to all of these things, and we're really choosing our cost. It's not like one is free, right?
Right, exactly. So that's one that I really think deserved a little more attention.
What about you, Christy? What grabbed you or got you thinking or any?
I was moved to tears. I believe it was Tuesday morning with the HIV among drug users plenary speaker who really focused on the high impact of the high burden of HIV among female intravenous drug users, as well as how the war on drugs keeps us from offering harm reduction techniques that could potentially be protective. I was really excited to hear her speak a lot about, I think she termed it addict phobia. I talk about it as substance use stigma, and in my research I look at the combination between HIV and substance use stigma because they really inform one another. And I was just really excited to see that brought front and center in one of the plenary sessions.
And I think it's one of the first plenaries at CROI that's ever focused on intravenous drug users. So I think I'm glad to hear that it was something you thought was important because it was, I think, an area that has been somewhat overlooked in the past.
And another critical community and population when we add in hepatitis C and how quickly that transmits in any kind of group that's sharing needles, for example. It's interesting, CROI is like a scientific bubble, really. All these fantastic researchers, over 4,000 people coming into one place, presenting all the best data. And it's all existing under this bubble where we think politics can't enter, and it's just really the pure science. And even in this just short amount of time, we've already identified several areas where politics is already well into our work. And we may as well, it seems to me, acknowledge it, understand it, and figure out solutions to it, beyond the medications and biologically how they work and which one works best,
Right.
We have to look at the whole people. I mean, as a positive person, I sometimes think there can be this attitude of getting at the virus, and we're just kind of in the way, You know?
Wow.
So it's really, I think now, maybe this many years into it, 30-some, that maybe we're at a juncture where it's time to look at the human element of HIV and AIDS. Finally.
I think you absolutely cannot treat, cure, vaccine, HIV, or any other condition ignoring the person.
Doesn't sound right, does it?
Right. Sociology, I've said, sociology sometimes is guilty of ignoring the biological aspects, and I think it's true the other way around. It really has to be a multidisciplinary approach to understand the whole person.
Maybe there will be more and more medical sociologists at CROI.
I hope so. I hope to be here next year.
Any final thoughts, either of you?
On that particular topic or other things we saw?
Anything.
Yeah. Well, I do think there were some pieces of good news at the meeting. I think we are beginning to see real progress in lots of new agents that could potentially be used for prevention. We saw some really exciting data, I think, in the session that you attended, Heidi, where some injectable agents are being evaluated that would potentially give people that option to have a very discreet method to protect themselves from HIV. We also heard about new film formulations of microbicides. So it looks a lot like a Listerine breath mint strip, essentially, but would contain enough antiretroviral drug in a very discreet and inexpensive form that could allow women to insert it and protect themselves from HIV. So it's I think, a time of great promise in terms of new technologies being brought forward for prevention that I thought were really exciting in the session that we attended on Tuesday.
Yeah, and I don't think I'm alone in thinking that until we have either a strip like that or some other method that women say works for them, and it in fact works in terms of prevention, that we're ever really going to get ahead of this thing. As long as women are really at the mercy of men when it comes to prevention.
Well, I still find, the discussions about people talking about, well, but did she use condoms? And I always say, well, exactly where would you put that condom? Exactly.
There we go.
The male condom is not something that women control very well or can really control, and men take them off. Even in the middle of sex sometimes. And it's, I think for anyone working in this area, and in the area of women's health, certainly we understand that women have to have tools that they can control to protect themselves.
Yep. I want to thank you both so much for chatting with me about these really very, very important topics that are, I think it seems like we'd agree to say, kind of woefully under-discussed, maybe under-researched. And thank you both for your research and the work you do.
Thanks, Heidi.
Yeah,
Thank you.
Thank you.